Hi everyone, my name is Sahdev Baweja. I'm part of SIGN at New York Medical College, and today I have the privilege of being joined by Dr. Ramakrishnan. She is a stroke neurologist as well as neurointerventionist. Dr. Ramakrishnan, thank you for joining us today.
Thank you very much. It's a pleasure to join you. As you said, my name is Dr. Ramakrishnan, stroke and neurointervention and head of the Northern Region's program development with Westchester Health System. So it's Mid-Hudson Regional Hospital and Kingston Hospital. Nice to be here with you all.
Thank you. So my first question for you is, what led you to becoming a doctor and then specifically a neurologist?
It's a very interesting question. I can only come close to the answer somewhat peripherally because you never know that you've gotten into the right area until time goes and then you look back. So what led me here was really continuing to keep following my interest. And my interest had been from an early age, just a little bit of curiosity all around, but a little bit more focused towards the brain and its inner workings. I pursued that and I did my PhD work, which was within the realm of Alzheimer's, but really trying to understand a very small segment of the molecular biology and cellular biology of Alzheimer's, which is really the professional foray into the brain and disease. And then as I completed my MD PhD program and did clinical rotations, it solidified that neuroscience is where my interests lay. And I continued to follow that and applied and undertook a neurology residency. And of course, that continued to confirm what I had suspected as my nascent interest. So that's the initial journey. And of course, that further progressed towards acute aspects of clinical neurology, which is really truly exemplified by stroke, all manner of stroke. And that led to me pursuing two fellowships, one in vascular neurology, colloquially called stroke, and then the second after that one is neurointervention.
So could you talk a little bit about the differences between the two?
Sure. Um, I'm assuming you're alluding to the two fellowships.
Yes, sorry.
Sure. So, neurology residency is the foundation for vascular neurology fellowship. So once somebody comes out of neurology residency, you of course can practice as a neurologist, a general neurologist, and you see the full gamut of what is seen as the neurologic diseases. But if you wanted to specialize, then vascular neurology is a boarded subspecialty within the field of general neurology. It's a 1-year clinical fellowship. People can do other things. They can add on a research year or do a research year and then do the vascular neurology. But clinical fellowship is a 1-year accredited fellowship, and there is a match. So people go through the match. And you really solidify your training in all manner of hyperacute, acute, and outpatient aspects of ischemic and hemorrhagic strokes. And it also encompasses other manifestations of neurovascular diseases. But generally speaking, it's, as I said, it's colloquially known as stroke, and that is really the bulk of what you're going to see and do. And it also allows you to really synthesize and integrate different diagnostic and therapeutic approaches, both evidence-based and those that are patient-centric. So it really combines so many different aspects of what one starts out doing in neurology. You start by looking at, is the patient acute or is there a temporality to their development that's longer? And then, you figure out, is this recurrent or is this, staccato? Is it, a chronic condition? It fits a very rubric way of thinking about it, but then you have to be, more thoughtful about your patient approach. It's playing detective, which is the best part about being a vascular neurologist. Now, vascular neurologists do procedures, but they're not necessarily invasive procedures. So some procedures that they can do are TCDs, so transcranial Dopplers are something that they can get extra certification in, or just by doing enough of them under mentorship, they could get certified and have to maintain active certification by reading so many studies every year. So that would be considered one of the procedures of vascular neurology. And what's rewarding about that is it's a bedside procedure. You take a TCD probe and put it right, in your insufflation windows in your calvarium. Temple is one of those areas. And you can actually see what's happening to blood flow in the particular vascular tree. And it integrates neurovascular biology in some of the most unique and interesting ways and helps you make decisions. As a vascular neurologist, you get very good at reading and interpreting CTs and MRIs for the benefit of your patients and to address questions and also use them effectively to tease apart diagnostic considerations. Those are not directly procedural, but they integrate and heavily showcase our use of radiologic tools in what we do. Vascular neurologists are an integral team for patients needing to be reperfused. So if somebody comes in with an acute stroke, they may have a large vessel occlusion causing the patient's stroke symptoms. A vascular neurologist is very much central to that patient's good outcome and longitudinal follow-up, even within the confines of the hospital. They work very closely with the interventional team and in a multidisciplinary way decide about patient selection, types of treatment, both emergent as well as immediate in the hospital. We talked briefly about the outpatient. So you get to see these patients when they leave the hospital and come back in clinic and see what an amazing recovery they may have made after any acute treatments that they have received in the hospital. And also continue to use outpatient resources, both physical, occupational, speech, and cognitive therapy domains to help them regain their function to return to life. So it really touches upon so many aspects of what it means to come professionally as a vascular neurologist. It's one of the few subspecializations that has such a far-reaching effect.
Thank you. That's definitely interesting.
The second thing that you asked me is the neurointerventional piece. So to be a neurointerventionalist, the pathway, only this year, I think the match is going into effect. So this will be the first year that there will be any formalized match. But so far, it's been where you look for programs and then you apply on your own and then, you follow the interview path and so forth. But generally speaking, your pre-application pathway as a neurologist is neurology residency, either 1-year vascular neurology fellowship as a prerequisite or a 2-year neurocritical care fellowship as a prerequisite. And then you then enter the neurointerventional fellowship. And typically that's a 2-year fellowship where you get trained on diagnostic angiograms, ischemic and hemorrhagic disease treatment, acute and emergent cervical and intracranial stenting, intracranial aneurysm management, AVM, dural AV fistula, and on the horizon and really becoming part of many interventionalist practice is this vast world of neurovascular venous diseases that have so far been really not fully explored, but are now getting the limelight. So even more indications for what a neurointerventionalist might be able to help with. So that encompasses in a very high level way as to what these two fellowships look like once the training is done.
Thank you so much. So, what would you say is a typical day or week in your life?
Mm. Uh, I start my day in the hospital, and I see inpatient strokes who don't need interventions, but do need the vascular neurology part of what I do to try and understand why they had their stroke and what could we do to identify the cause and how should we proceed towards treatment. So we'll be seeing patients in the ICU, patients on the floor to address the next steps in their journey. When I'm on call for neurointervention, a patient coming in with a proximal large vessel occlusion, for example, with still a fair amount of brain to save, would be somebody that they would reach out to me. And after assessing their eligibility and potential for benefit, go ahead and take them to the lab and try to revascularize the occluded area and save what brain can be saved before it dies and suffers the full extent of the stroke. And after the procedure is done, you still follow them through their ICU and hospital stay. Same thing, but in an elective side, may need to see a patient with a symptomatic carotid stenosis. They've come back and have to treat that now in a non-urgent but an immediate way. You could treat or diagnose patients with who have pulsed tinnitus or idiopathic intracranial hypertension. If they have any venous pathology that might be amenable to treatment, then do diagnostic cervical and cerebral angiogram as well as a venogram and manometry, or do daily diagnostic angiograms on patients who need it, both inpatient and outpatient, treat aneurysms. So it really is the full gamut. And on any given day, I'm doing a mix of procedure plus inpatient. And on some days, that as well as outpatient. And this happens whether I'm on call or not on call. So it's a full schedule. And of course, there's medical students that rotate with us, and there's teaching involved. And we go to conferences, so we do scholarly work, and you prepare and present. So it's really the three pillars: clinical work, education, as well as research. All of them form my time at work.
Okay. And is there a breakdown between how much is vascular versus neurointerventional versus teaching research, would you say, or they're just combined?
You're always doing all of this, which is exactly what you're talking about, right? So neurovascular discipline as an entity, a practicing specialty, I should say, with more therapeutic options than ever before, is a more recent development, last 20, 25 years. And that even within the 20, 25 years, the last 7 to 8 years have really been on a different and a much more steeper trajectory. And that has only been possible because of us constantly reviewing and refining our approaches. And you can't do that if you don't learn from every case, if you don't try to test your hypothesis in real time where you can. So these are all germane to everything that I do, but in a more formalized way, my clinical role is, I would say, probably 85% with research and education comprising the remainder, but that's a very crude breakdown. It's way
Okay.
more.
Okay, and just as you were mentioning that this whole field has changed greatly, what have you noticed in the changes and where do you think the field is headed in the next 15, 20 years?
So what is certain is this field will continue to change. So that is a certainty. And the pace of change is not additive. It's been on an exponential trajectory. When the first of the successful thrombectomy trials came out, we were in 2014, 2015, and every 2 years, there's been new data coming to change your practice pattern in an evidence-based way to give more patients access to treatment, with the caveat that patient selection is key. But assuming that that's a given, the change has happened every 2 years, and more recently, it's now actually a year to 18 months. So the pace of change in being able to extend the treatment to include more and more patients has skyrocketed. It's because of a lot of things, but some of those have been dependent on the availability of material science making some of these devices much more facile to reach the target of treatment. The other components are within the realm of radiology and how patients are being triaged with various imaging modalities to identify solutions for them. And people getting to know that there are treatments that are now standard of care. So getting the word out has been the other development. As I alluded to earlier, now we're not just treating diseases on the arterial side, but we're also treating diseases on the venous side. So I mentioned two entities. One is idiopathic intracranial hypertension, where typically young women, but not exclusively, have threatened vision, which can be transient, but also have a constellation of other symptoms like difficulty concentrating and headaches. They can have papilledema, really a scary set of symptoms that can rob them of the rest of their life. They can go blind. And in the past, the treatment options were there, but with the advent of neurointervention for these patients, now you can understand the pathophysiology as being, at least in some of these patients, a venous outflow problem. We know what to do when there's an arterial inflow problem, like with a stenosis or an occlusion. If it's occluded, open it up. If it is stenosed, put a stent. Well, on the venous side, you can have the same problems. Could a stent work and help relieve the bottleneck and the congestion and relieve the increased pressure in some of these patients' brain and make them better so they don't have any more long-term issues? And that's been shown to be very effective in many of these patients. And again, patient selection is key. Same thing for pulse tendinitis, another emerging paradigm. Venous sinus thrombosis, another disease that somehow more commonly than not affects women with hypercoagulability. And again, if you thrombose the draining veins from the brain, you would back up blood flow and increase pressure. And in fact, it can have multiple sequelae that can actually be life-threatening and people can die. So, many of these are now extending into the venous side. On more of what might come based on some advances, there are brain-computer interfaces that could be placed in certain parts of the brain's vascular tree to see if thoughts could be deciphered and use them via a computer interface to control the patient's environment to replace loss of function in patients who have lost control of their arms, for example, but are cognitively otherwise capable of thought. So that is very exciting. It's not prime time, but lots of developments are happening there. Another window into what might be coming are patients who have needed CSF diversion because you have three general principles, general components within the brain that govern how pressure and volume are regulated in the brain. You have the substance of the brain, you have the blood volume in the arteries and veins, and then you have the CSF. So if there is a problem for CSF drainage, for example, then people have conventionally put in VP shunts. But what if you could try to recreate how CSF actually drains out of the brain, which is for a good bit via the dural veins, and try and create a conduit between the CSF compartment and the dural veins and create another one-way valve and do it endovascularly. So again, this is not yet for prime time, but again, people are actively looking into this to see what are the parameters to test and assess its efficacy, and then the patient scenarios where it might be most applicable. So all of this is probably in the next 5-10 years. Longer term, what was previously not endovascular may become endovascular. It's just imagination, and finding a way to do it is what's going to be key, I think. So it's a very exciting time to be in this field.
That's really cool things you just mentioned, and we're hoping to see them come to light in the not so distant future. What challenges do you think, or do you see neurologists facing today?
Um, ever more we have information that is both your friend as well as showcases our inability to keep pace with this onslaught of information that's coming at a rate that we're not able to fully absorb, digest, and integrate. So I think trying to find a way to really pick out the information, ascertain its, validity for what you're trying to answer, and then also try to see how best that can help your patients has always been a challenge. But I think in this information age and AI world era, that would be one of the key issues that I think, no matter the discipline, we are all going to face and are facing. So it's something that's going to be a steep learning curve for all of us, and I foresee that as being one of the issues that also affects neurologists. Neurologists fundamentally are critical thinkers and keen observers. And one of the caveats to keep vigil against is to not forget that that really is some of our tool and strengths, and to constantly try and take stock of information that's coming at us for what we might need to, how do I say it, to ensure that we are not blinded by the amount of information and forget to use critical thinking or stop being observant. Our cognitive stacks are still very valuable. So our strength comes from being able to lean in on that in the way that we've always done. So I would hope that that doesn't change.
Okay. And what advice would you have for someone who's looking or thinking about pursuing a career in neurology or interested in the field, starting out in medical school?
Um, having a really broad foundation is going to make you better no matter the discipline that somebody chooses. And for neurology, it's very true. Neurology does not live in isolation, and neither does any other field. So having a really strong foundation in the basics. So what is that? Internal medicine, surgery, family medicine, pediatrics. These are all key grounding disciplines that you really would benefit from making sure that you really get the best of your time being spent in those disciplines, because how strong you are in them makes you a stronger neurologist. So it is really, really exciting to enter the field of neurology. And I think that's where some of the cool things are going to be happening. But in order to take advantage of all that, you would have to come with a strong foundation. So, if you knew that already, that would be fantastic. If you were unaware of that, then I think as a practicing physician in this field, it is going to be absolutely key to have a strong foundation. And I rely on that every day. I use my internal medicine, surgical, peds, and family practice principles without even thinking about them. And that's made me a better provider.
That's definitely good advice. For our last question that we like to ask everyone, what's your favorite part of the brain or central nervous system and why?
um, it's a tough question to answer, but I'll answer it in the way that I know resonates with me, okay?
Sure.
It's not, I don't think we know the seed of this, but I would say it's imagination. Imagination is absolutely essential for all things we do and aspire to. Without that, we're doing the same thing every day. Imagination allows you to look at a problem and, come up with a potential testable solution. And then you have the choice to see whether you would exercise that test. But without that, we have no progress. So I don't know what the seed of imagination is. If somebody knows, I'd love to know. But imagination is absolutely important. And that's very refreshing to me.
Well, Dr. Ramakrishnan, thank you so much for your time. It was definitely really insightful hearing from you and, everything you had to say. I'm sure all our listeners will learn a lot. Thank you so much.
Well, thank you for this opportunity and you have a great day.